Good afternoon, everyone. Next few minutes we'll be discussing about the novel or recent lipid lowering agent. Now that we had a surface lunch, our LDL cholesterol must have increased substantially. Globally, atherosclerotic cardiovascular disease is the leading cause of CVD morbidity and mortality. Nearly 10% of these patients have recurrent events like MI, stroke, or cardiovascular death in the first 3 months, and it extends up to the first 1 year. And increased LDL cholesterol is one of the top modifiable CVD risk factors. And the important risk factors, 3 important risk factors, are hypertension, diet, and high LDL cholesterol. The LDL cholesterol, one concept we should know is the magnitude and duration of the LDL cholesterol exposure. Somebody at the age of 20 years, he's having a LDL cholesterol of 150, or somebody is having, another person 20 years of age having LDL cholesterol of 125, another having 100. The lifetime risk increases, though the value appears to be normal, say 125, 140, it is more than the lifetime risk is more than what a LDL cholesterol of 100 has. So plaque burden can be calculated from LDL cholesterol and duration of the exposure. So it's a simple multiple. As the plaque burden or the lifetime risk increases, obviously the potential myocardial infarction increases. For every 1 millimole per liter increase in LDL cholesterol, risk of myocardial infarction is 30% higher. 1 millimole comes to approximately 40 milligram percent. In the real world setting, show a huge gap in dyslipidemia management and the need for intensive lipid lowering therapy. Across the world, we see the studies from Europe and from US and from India. LDL cholesterol, the goal of having LDL cholesterol less than 55 milligram per deciliter, which is as per the 2019 ESCAS guidelines, they could not achieve in nearly 80% of the patients. So only 20% of the patients across the world, they could achieve the LDL cholesterol goal of less than 55%. The role of earlier combination therapy in high-risk ASCVD individuals has to be emphasized. So this is time to prioritize early combination therapy and early non-statin use for high-risk patients. Starting combination of lipid lowering therapy at diagnosis in high-risk patient reduces the treatment delays and ensures faster LDL cholesterol reduction with dual benefits in the 4 to 5 weeks. See, when the patient comes with acute coronary syndrome, the plaque is vulnerable. The lipid plaque contains liquid lipid. It is highly inflammatory and thrombogenic. In the first 4 to 5 weeks, it's very important to decrease the LDL cholesterol as much low as possible. That can be achieved with the novel therapies more than the statins. Indian patients are also at higher risk as per the Clarify registry. Indian patients, compared to the world patient, the international patients, outside India, as a general rule, our cardiovascular disease is about 10 years younger than what is in the Western population. And proportion of patients with raised LDL cholesterol, reduced HDL cholesterol, diabetes with poor glycemic control is greater. It's what we call metabolic syndrome. South Asians have a propensity for this metabolic syndrome with low HDL, high triglycerides, and these patients tend to have small dense LDL, which is supposed to be more atherogenic. And the real world evidence from India shows, same as mentioned earlier, 80% of the ACS patients not reach the current LDL goals. At baseline, only 5% will have LDL cholesterol less than 55 milligram percent, and less than 70 milligram is seen in about 10%, and less than 100 milligram is seen in 29%. So at follow-up also, slight improvement but not much. 80% of the patient did not achieve LDL cholesterol less than 55 milligram even after 1 year after the ACS event. More than half of the patients failed to achieve LDL cholesterol less than 70, And all patients, it has to be important note, all patients were on statins with 96.6% initiated on high intensity statins. So which means what? High intensity statins alone are not sufficient to reach the LDL cholesterol less than 55% of the 55 milligram percent. So, and also number of pills that has to be taken, therapy adherence. If you are taking statins, it has to be taken every day. What are the other molecules? Ezetimibe, bempedoic acid, they have to be taken every day. If you are taking PCSK9 inhibitors, it has to be taken every 2 weeks. And if you take inclisiran, which we are discussing today, it has to be taken once in 6 months. So the magnitude of the reduction in LDL cholesterol is directly proportional to the reduction in the CVD events. Here you can see how do you get this? Here you can see as the magnitude of with statins, you get a lesser reduction in the LDL cholesterol, slightly better with monoclonal antibodies, and much more with the small interfering RNAs. So what are the questions that we have to discuss? How low would you go with respect to the target LDL cholesterol levels for your very high risk ASCVD patients? Now, the guidelines say 55 milligram percent. That is, but we have got data from the other studies that LDL cholesterol of 25 is better than LDL cholesterol of 35, which is better than LDL cholesterol of 45. So how do we get these numbers? There are various reasons for that. It's beyond the scope of this topic, but suffice is to say, lower the LDL cholesterol, there is no harm to the body, no increased risk of cancer, no cerebrovascular cognitive problems, but there will be definitely a benefit in the reduction of the ASCVD events. How soon do you recommend evaluation of escalation of lipid lowering therapy in your post-ACS patients? One should know that the maximum events occur in the first 2-3 months. Earlier you stabilize the plaque, decrease the inflammation, decrease the thrombogenicity, that's better. How do novel therapies like inclisiran fit in the current lipid lowering space? We are going to discuss that. What are the salient clinical evidence and guideline recommendations for inclisiran? Which ASCVD patient types do you think would most benefit from a novel therapy like inclisiran? How can we overcome cost as a barrier with novel therapies like inclisiran? What are the real world evidence? We will be three of us, myself, Shashikanth and Srinivasa, will be discussing this. How low would you go with respect to target LDL cholesterol for your very high risk LDL patients? Here if we see 2023 ASC guidelines, when the patient presented, if the patient is treatment naive, you start them on the high intensity statins, and if they are suboptimal LDL therapy, you increase to the high intensity statins, and then if the patient is on high intensity statins, then if the patient is reached already less than 55 milligram percent, we can continue, but otherwise we add ezetimibe. Once we have all the high intensity statins and ezetimibe on board, if the patient does not reach LDL cholesterol levels, then we have to add the non-statin therapies. Similar are the guidelines from the ACS. In patients with ACS, high intensity statin therapy is recommended to reduce risk of MACE, and level 1 class 1 indication in patients with ACS who are already on maximally tolerated statin therapy with LDL more than 70, adding a non-statin therapy lowering agent is recommended to further reduce. So 70 is not sufficient. One should not be satisfied 70 is there. We have to bring it down. If it is already on high intensity statin, add ezetimibe or non-statin therapy. In patients with ACS who are already maximally tolerated statin therapy with LDL 55 to 69, and adding a non-statin therapy lowering is reasonable to reduce the risk of MACE. Sometimes we say, what is the big difference between 60 and 55? If you calculate, it is 10%. So 10% reduction, this figure is not there, but 1% reduction in LDL cholesterol decreases the CVD events by 2%. So bringing down from 60 to 55 is important. So you need not brush aside that is already 60, what is there, what is the difference between 55 and 60. In patients with ACS, the concurrent initiation of ezetimibe in combination with maximally tolerated statins may be considered to reduce. This is the class 2B indication. Statin intolerance is fairly common. In patients with ACS who are statin intolerant, non-statin lipid lowering therapy is recommended. So what are the non-statin therapies? The available ones are ezetimibe, PCSK9 inhibitors, and bempedoic acid, and this includes inclisiran, which is a non-statin therapy. So again, hit hard and hit early. So if the patient is having acute coronary syndrome or LDL cholesterol is not target, we give the high intensity statins. High intensity statins are atorvastatin 80 milligrams, rosuvastatin 40 milligrams. And if we don't reach, the summary of this slide is, if the patients with chronic coronary disease or acute coronary syndrome, the LDL cholesterol should be less than 55. You start with atorvastatin 80 or rosuvastatin 40. And in patients elderly, more than 75 years or with CKD, then you can have atorvastatin 40 and rosuvastatin 20. And you monitor these patients, you repeat after 4 to 6 weeks, and 4 weeks is sufficient. Actually, 6 weeks is not required. After 4 weeks, you look at the fasting lipid profile and our direct LDL cholesterol estimation. If the LDL cholesterol is less than 55, it's okay. Otherwise, we have to add the non-statin therapy. Another thing is, we have to, if the patient has reached LDL cholesterol of less than 50, you should also look at the non-HDL cholesterol. The non-HDL cholesterol should be less than 45.